Hello, YouTube. This is Rachel Self with Otsuka Pharmaceutical Development and Commercialization. Recently, PsychU hosted a webinar titled Addressing Unresolved Symptoms of Major Depressive Disorder, a focus on norepinephrine. During this discussion, our speakers, Dr. Joseph Goldberg and Dr. Vladimir Maletic, provided some really riveting discussion on unresolved symptoms of major depressive disorder, the proposed role of various monoamines with a focus on norepinephrine in patients still suffering from major depressive disorder, even after remission from various treatment modalities. As always, the program was sponsored by Otsuka and Lundbeck, committed supporters of the mental health treatment community. Speakers are paid consultants to OPDC, and I am an employee of OPDC. Let's look at a few clips from the webinar.
A major depressive episode is the constellation of not just mood, cognition, sleep-wake cycle, feeding behavior, motivational behavior, psychomotor functions. It's a panoply of lots of symptoms, but residual low energy, sleep problems, attentional processing, cognition problems linger, breed, seep into psychosocial functioning, make it harder to recover. We often talk about the gap between symptomatic or syndromal recovery and then functional recovery. And as many of you probably know, one of the reasons why depression is one of the leading causes of disability in the world isn't just because we haven't fully gotten rid of your lethargy and your anhedonia, but the translation of, am I back to work? Am I able to go back to school? Can I take care of my family? Can I have meaningful interactions with friends, with colleagues? My quality of life often lags behind quite a bit, and that can lead to things like absenteeism or presenteeism at work, difficulty in maintaining households, and we get into systemic problems and comorbidities. So for a host of reasons, all these things that linger on can become very difficult and recalcitrant and harder to treat. So this graphic just describes some of the incident rates that we see of residual symptoms across domains. So the goal always should be to try to eliminate symptoms as closely as possible and to monitor for signs of relapse, because residual symptoms are a big trigger for relapse.
So we will try to expand this topic by talking about some of the important principles of neurotransmission. And the concept that I would like to introduce at this point is the concept of allostasis, where allostasis is dynamic and adaptive homeostasis. So is the transmission at the optimal level or not does not only depend on the concentration of a given neurotransmitter. It depends on the proportion between the level of transmission and environmental demands. It depends on the context. So we will use norepinephrine transmission as an illustration. So you see here that we're looking at curvilinear relationship. So it looks like a rainbow, and neither ends of this rainbow are particularly good. So what happens if there is not enough norepinephrine? If there is not enough norepinephrine, our patients may phenotypically report somnolence. I'm sleepy, I'm tired, I have little vigor, it is hard for me to concentrate, I keep on getting distracted, I have a hard time completing tasks. So this is what not enough norepinephrine looks like. If we have the optimal amount of neurotransmitter, given the circumstance, and when I'm talking about neurotransmitter, I want to indicate to you that this mostly reflects cortical scenario, although some of the presentations that we are addressing here will have to do with so-called top-down regulation, so how cortex regulate subcortical structures, including subcortical components of limbic system. So not enough norepinephrine, not good. Optimal concentration of norepinephrine. We are alert. Our arousal is exactly where it needs to be, which means calm wakefulness. We're able to focus, our working memory is good, and so-called top-down regulation of emotion is very efficient.